risperidone in October of 2002, olanzapine in March of 2004, and all atypical antipsychotics in 2005. These warnings serve to slightly reduce the rate of increase, but certainly did not lower that rate to zero. There continued to be substantial rise in the use of the atypical second-generation antipsychotics. After the first warning, which was focused on the atypical antipsychotic risperidone, the fall, the up to that time continuous fall in the use of first-generation antipsychotics flattened out as clinicians switched back to those drugs, making the judgment that cardiovascular death was more of a concern than movement disorders such as TD. Looking at individual drugs, the use of risperidone tended to flatten out substantially after the first and then the second and third warnings. The use of olanzapine, in fact, reversed and started to fall after the olanzapine warning in 2004. But the use of quetiapine steadily and consistently continued to increase despite all three warnings. In summary, the benefits of antipsychotic medications for people, elderly individuals with dementia, seem to be very small to non-existent in terms of group effects. This certainly does not mean that there are not individuals who can benefit for periods of time to reduce agitation, to reduce the fear or excitement produced by paranoia or hallucinatory experiences. But even in these individuals, an effort should be made to use the lowest effective doses, and an effort should be made to gradually discontinue the medication in as many patients as possible. Let's move now to consider the use of these drugs in children and adolescents. It is estimated that as many as 20% of children and adolescents will meet diagnostic criteria for some mental disorder before they reach adulthood. On one hand, it's wonderful that we're paying more attention to these early onsets, early manifestations of significant psychiatric disorders, and perhaps we can intervene and be helpful to make the important years of childhood and adolescence most productive, most useful, most fulfilling for these individuals. But unfortunately, we're rushing in with treatments that have had very, very little study in these populations, and that have a substantial burden of adverse effects. In the Archives of General Psychiatry, Gonzalo Laje and his colleagues from Colombia noted that there was a six-fold increase between 1993 and 2002 in the number of prescriptions for antipsychotics written for children and adolescents, from approximately 200,000 to 1.2 million in the course of those years. They found that 92% of these prescriptions were for the newer second-generation antipsychotics, which had not been approved at that time, though several have recently been approved by the FDA. The prescription rate was significantly higher for white, non-Hispanic male youth than for female youth or youth of other racial and ethnic groups. And interestingly, the disorders for which antipsychotics were prescribed were primarily disruptive behavioral disorders, followed by mood disorders and developmental disorders, and only very few of these prescriptions were for psychotic disorders. So these drugs were being used along the lines originally foreseen by Laborit and DeLay and Denneker in terms of quieting, soothing, sedating, and generally reducing the agitation of individuals rather than for an antipsychotic purpose. Mark Ulfson and colleagues noted that among antipsychotic prescriptions written for children and adolescents, the great majority, 84%, were provided by psychiatrists, and that antipsychotic prescriptions were written at 18% of psychiatric visits. Only in 36% of visits among patients receiving an antipsychotic was any psychotherapy or psychosocial intervention included. And the most frequent mental health diagnoses were disruptive behavioral disorders, 38%, mood disorders, 32%, pervasive developmental disorders or mental retardation, 17%, and only 14% for psychotic disorders. And these patients receiving an antipsychotics, in 1/3 of the cases, were simultaneously receiving an antidepressant, and in 1/3 of the cases were receiving a mood stabilizer. I want to briefly mention the TEOS, T-E-O-S-S study, a large 6-year multi-site NIMH trial called the Treatment of Early Onset Schizophrenia Study, examining 116 youth between 8 and 19 years of age diagnosed with an early onset schizophrenia spectrum disorder. These youngsters were randomly assigned to 8 weeks of either olanzapine or risperidone or the older conventional antipsychotic molindone. Response rates after 8 weeks of treatment were comparable. In fact, the response rates for molindone at 50% were higher than those for risperidone, 46%, or olanzapine, 34%. And children taking olanzapine or risperidone improved a little bit earlier, but that is by the 2nd week. But by the 3rd week, molindone had caught up and in fact slightly surpassed the other 2 treatments. The groups, however, were not the same in terms of side effects. The children taking olanzapine over this relatively brief study gained an average of 13 pounds, and those taking risperidone gained an average of 8 pounds, whereas those taking molindone did not gain weight. The olanzapine group also showed increases in cholesterol levels and other metabolic disruptions, and the Data Safety Monitoring Board ended the olanzapine arm of the study well before the entire trial was discontinued. It's also worth noting that as of May 7, 2008, in Psych Central News, it was mentioned that children in the U.S. are 6 times more likely to have an antipsychotic medication prescribed relative to children in the UK. In the UK, approximately 4 to 7 children per 10,000 receive an antipsychotic prescription. In the U.S., it's 23 to 45 per 10,000. Let's move on. Well, before we move on, again, a brief statement. It is, I want to be clear that I'm not saying that the use of an antipsychotic in children is good or bad. What I'm saying is that it is increasing tremendously in the U.S. with very few studies documenting the need, the indication, and also very few studies comparing older conventional antipsychotics with newer atypical antipsychotics, but those few studies suggest there is no advantage for the newer drugs. Judiciously used, sensibly chosen older drugs, molindone, perfenazine, thiothixine, loxetane, used in low doses, may be very effective for many children